Today I'm going to talk about, I'm Dr. Kishore Jayanti. I'm a consultant pediatric cardiac intensivist and head of ECMO services at Star Hospitals, Hyderabad. Today I'm going to talk about VV and VA ECMO in neonates. Okay, so let's talk about VV ECMO. Most of the ECMO in neonates is VA ECMO as of now in most parts of the world, but the current trend is changing towards VV ECMO. So this diagram is a representation of both VV and VA ECMO in children and adults, but not in neonates because I'll come to that later. First, we understand the circuit and then we'll move on to the next um, topics. So in VV ECMO, usually in children and adults, we take the drainage from the femoral vein and return back to the internal jugular vein. This VV ECMO is used for oxygenation failure and ventilation failure, that is the carbon dioxide retention. So it's in impaired gas exchange with respiratory failure, despite managing on maximal medical therapy, including advanced ventilator therapies, if the child or neonate is not maintaining on this advanced oxygenation ventilation like HFO and nitric combination, then we are sometimes even we don't use that, but if the oxygenation index is increasing, then we switch over to the mechanical circulatory support, which is VV ECMO or VA ECMO. Okay, in respiratory ECMO in neonates, we can either do VV ECMO or VA ECMO. If we do VV ECMO, we cannulate two veins, two great veins. If we do VA ECMO, then we take the drainage from the internal jugular or femoral vein and return back to the carotid artery. Okay, so let's talk about VV ECMO. So in neonates, the larger vein is internal jugular vein. So we take the drainage from the internal jugular vein, which drains from the SVC and then returns back into the IVC into through one more cannula, return cannula. So here there is this, you can see the circuit here that there is a pump which is shown in the red that will sorry a pump which is shown in white that is taking the blood out with a centrifugal action by negative pressure, and that pumps after that the pressure will be positive, and that pushes into the oxygenator, which oxygenate and removes the carbon dioxide from the blood, and after that the blood is returned back into the patient. In VA ECMO, the same thing is done, but you are returning back into the artery instead of a vein. Okay. Now, what is the purpose of ECMO? So it's to maintain oxygen delivery and facilitate carbon dioxide removal. It is to maintain cardiac output in kind of cardiac failure and ensures good tissue perfusion and microcirculation. It also prevents volume and barotrauma of the lungs, and it helps in recovery of both lungs and heart by transiently replacing their function. So in this process, we are giving rest to the heart and the lungs. So in VV ECMO, what we are doing, we are only giving pulmonary support because we are draining from a vein and returning back to the vein. We are only removing the carbon dioxide and giving the oxygenated blood to the patient. So, but cardiac support is not there. Whereas in VA ECMO, both cardiac and pulmonary support can be provided. And the mixed venous saturation is not reliable in VV ECMO because there is a lot of mixing and recirculation. In VA ECMO, mixed venous, the pulmonary artery saturation is more reliable. In VV ECMO, it's a pulsatile flow because heart is intact and heart circulation is good. The cardiac output is good. In VA ECMO, it's a non-pulsatile flow in case the heart is totally stunned and not contracting at all. In that case, you see mostly a mean BP with no much gap between systolic and diastolic blood pressure. So you see hardly like five pulse pressure. It's because heart is not ejecting. In VV ECMO, if emboli go, they go to the pulmonary artery side. Whereas in VA ECMO, they go to the systemic circulation. VV ECMO, because it's going back to the vein, there is no afterload. Whereas in VA ECMO, there is a significant afterload to the heart. And so there is also a resistance from the artery. Okay, so we have to ensure that there is no afterload, otherwise it will not flow. Again, this afterload also can cause more resistance to the heart. because of the competitive circulation from the native heart and the ECMO circuit. So the flows requirement is in VV ECMO is as per the saturation and oxygen delivery, whereas the flow requirement is guided as per the tissue perfusion requirement in VA ECMO. In VV ECMO, because you're either draining from SVC and returning to IVC, or draining from IVC or returning to SVC, there is a recirculation of the same blood possible, causing patient hypoxia. Whereas in VA ECMO, because you are returning back to artery, there is no recirculation. So oxygenation in ECMO depends on the oxygenator surface area, the hemoglobin concentration of the patient, the inlet hemoglobin saturation to the membrane of oxygenator. Usually the oxygenator used is polymethylbenzene, which is long lasting for 3 to 4 weeks. Okay. And carbon dioxide removal is a function of membrane lung surface area and blood PCO2 and sweep gas flow. What is sweep gas? It's like a blender in your CPAP blenders and all, where if you increase your flow, the CO2 removal will be there. And if you increase the FiO2, like our routine blender, so it will it provides oxygenation. So this blender is connected to the oxygenator in the ECMO circuit. So in ECMO circuit, what are the components? You have a centrifugal pump, you have oxygenator, which is supplied with oxygen through a blender. Then you also have the heater cooler, which actually provides good heating supply to the ECMO circuit. So you have three settings in ECMO, that is ECMO blood flow, sweep gas flow, and ECMO FiO2. So ECMO blood flow, usually we start with 20 mL per kilo per minute and gradually increase every 5 to 10 minutes by 10 ml per kg per minute up to target what we want. And the sweep gas flow is usually set at 0.5 to 1, the ratio of ECMO flow. So if your ECMO flow is like 1 liter, you keep a sweep gas of 0.5 and titrate according to your blood ABG PCO2. FiO2 is usually kept at 100. Later, we titrate according to the PO2s we desire. Okay, usually in VV ECMO, the PO2 is like 60, 65, 70 maximum because of mixing and recirculation. So usually like in regular arterial or central line circuits, we transduce the ECMO circuit to the monitor and we see the pre-pump, that is before pump, and then pre-membrane, which is the pre-oxygenator, and post-membrane, which is post-oxygenator, all these pressures. Okay, and then we keep the pre-pump pressure less than -50. And pre-pump and post-membrane pressure are before and after the oxygenator. The difference between them is called delta pressure. And we have a baseline pressure which we monitor and see where it is changing, it's increasing or decreasing, and based on that we come to a conclusion whether oxygenator is properly working or not. We are not going into the details of all those things right now, but we will go through rest of the details of PV and VA ECMO. So we have to cannulate. For this, we have to basically give heparinization to the patient up to 50 to 100 units per kilo of heparin. After that, we ensure the cannula position is adequate, and we ensure that there is no much afterload to the ECMO circuit in case of VA ECMO, and there is enough preload to the circuit, and the RA is filled up. So there should not be hypovolemia, so that the ECMO circuit can function well. Okay. In VA ECMO, once we go on to the ECMO, we reduce the inotropes of vasopressors because we don't want the heart to struggle and get tired with the inotropes. We want the heart to rest. Okay, now coming to the indications of ECMO. So in ECMO, we have many indications like PPH, meconium aspiration, like congenital diaphragmatic hernia, and multiple anomalies with omphalocele gastroschisis, etc., which can lead to PPHN. And there are sometimes it is myocarditis, cardiomyopathy. These kind of things can warrant ECMO, because if we are unable to manage on double inotropes with inotropic score exceeding 25 and lactate is increasing, then we have to put them on ECMO so that we can give rest to the heart. And sometimes in cardiac arrest, if we are unable to establish a return of spontaneous circulation, we have to do eCPR. So PPHN and all what happens because there are so many real causes for PPHN like highly membrane disease, meconium aspiration, and some irreversible causes like alveolar capillary dysplasia, etc. So in these situations, we have to put on ECMO and see whether patient is recovering or not. We have to do all the best possible things for the lung to improve. Until then, we have to provide ECMO support. Okay, in congenital diaphragmatic hernia, there is alveolar hypoplasia leading to pulmonary hypertension. So that can lead to a lot of problems. And sometimes we put on ECMO and then operate these diseases. And in omphalocele, etc., there is again same lung hypoplasia due to multiple genetic issues and other problems. So we have to also give ECMO support if they don't have too many comorbidities and irreversible problems like CNS, major CNS injury, etc. So let's come to respiratory ECMO in neonates. So what are the indications? In neonates, an oxygenation index of more than 30 to 35 on optimal treatment for 4 hours or more than 25 on nitric oxide should raise a prompt discussion with the ECMO center for possible ECMO. And if this neonate has the pneumonia or bronchopleural fistula or air leak with OI of 25 with nitric, etc., then you need to consider early ECMO for preventing the barotrauma and recovery early. So again, if PCO2 is more than 12 kilopascals for more than 3 hours, again, we should think about early ECMO referral. Okay, so coming to this flow chart, almost the same indications are mentioned here, but we will be discussing like in the tissue way. If you have inadequate tissue oxygen delivery with rising lactates, worsening metabolic acidosis, severe hypoxemia with PO2 of less than 40, and oxygenation is continuously rising, oxygenation index with no improvement, and there is severe pulmonary hypertension with left or right ventricular dysfunction, then you have to go for VA ECMO or VV ECMO depending on the requirement. If cardiac support is too much required, we have to go for VA ECMO, otherwise VV ECMO. So if you go for dual, like the double lumen venous cannula is also available, but that is not there in India right now. That is called Evelyn cannula. If you do that, you can only do net cannulation, but you have two ports. When one is for drainage, one you have to return back. That we'll talk about later. So what are the absolute contraindications? Like lethal chromosomal disorders like trisomy 13, 18, etc. But no other disorders you can consider for absolute contraindications. Then severe brain damage, uncontrollable bleeding, severe significant intraventricular hemorrhage, and vessels too small for cannulation. Okay, and now coming to the targets, VA ECMO, we accept the mixed freeness of around 65 to 80%, whereas in VV ECMO, it's not so much reliable. And saturation is more than 90 to 95% in VA ECMO. In VV ECMO, we can even consider 80 to 90 as okay, as long as tissue perfusion is well maintained and no hypoxia is there to the tissues. And PO2 usually 60 to 80 in VA ECMO and 40 to 60 or sometimes 50 to 60 or 70 in VV ECMO. And PCO2 again normal 35 to 45. So in weaning, what we do usually in VV ECMO, we come down to 50% of the we come down to we do not really wean the flows in VV ECMO because we are testing the gas exchange. So we actually wean the sweep gas and the FiO2. And if the patient is tolerating well, then we increase the ventilation and then come out of ECMO. Whereas in VA ECMO, we wean the flows because we are testing the cardiac output. Once the flows are weaned, if the heart is able to sustain, then there is a good cardiac output, good ejection fraction, then we wean off VA ECMO as well. Okay, that's the overall introduction of both ECMOs, VV and VA. Now let's come to VV. What are the newer concepts in VV? So as I said, that's even for respiratory failure, most of the times VA ECMO is used for neonates. But what recently, because of the size of the vessels, it's difficult to cannulate them for VV ECMO. Most of the time, as of now, people have been from so many decades have been restricted to the only VA ECMO. But of late, in some centers like St. Guy's and Thomas, like Dr. John Lee and all, what they started is they started cannulating the IJV for drainage, and then they are providing the return into the femoral, as you can see here. But there should be enough gap between both cannulas to prevent recirculation. So you drain from the IJV, like you can put 10 French cannula in the IJV and then return through 8 French return cannula or aortic arterial cannula into the so you trick drainage from SVC from and then return back into the IVC, okay, with an 8 French cannula. But while do you do this, you have to be very cautious and monitor your limb perfusion, limb edema, all that can be there due to congestion. So we have to watch for that. So this is the technique. You have to assess the patency of the vessels with ultrasound, and take you should not put any lines in that limb. And the right, you select the right-sided limb, then go for semi-open technique, semi-Seldinger technique. Cannulate both the vessels with ultrasound. Check your guide wire position. Then after that, go give heparin after your guide wire goes in. Once the heparinization is done, insert your cannula. Then after that, limb has to be elevated to prevent the congestion. And then it has to be regularly monitored with the Doppler. So at once you're off ECMO, you can decannulate and reconstruct your vessels. That has to be done by surgeon. Again, you have to monitor your vessels for the next 48 hours with and you have to use low molecular heparin after that also, and keep the patient under follow-up. You can see that there is some thrombus in the iliac here, and then rest of the vessels are uh, good here. Each external iliac vein has some thrombus there, but rest of the vessel is okay. The flow is good. So this is another technique. It's a double lumen cannula, which provides VV ECMO for neonates. But the challenge is you have to return, when you return your flow, it has to be directed towards tricuspid valve. Securing the cannula in this position is extremely difficult. You have to do under transthoracic echo guidance or fluoroscopic guidance. If the position is not good, there can be a lot of recirculation. So currently it's not being done in neonates. So it's because more challenging for neonates. So hopefully we'll get a better one in the future with good positioning and all that. Strategy of ECMO in VV ECMO is to prevent recirculation. Once the patient improves, the compliance improves, the tidal volumes improve, the plateau pressures are less than 28. So increase your ventilation. With that, the patient compliance is better. Chest X-ray is getting better. Then wean your sweep gas or FiO2, and then start weaning off your patient. Okay, and then when you're on off ECMO, again your OI should be less than 20. And you should not require too much of ventilation. You should be on moderate settings, and you should be able to manage your targets with PF ratios of around 200 or so. So coming to again overview of further ECMO management for both VA and VV ECMO, and then we'll go to the VA ECMO. Flow depends on the cannula size and resistance from the cannula and the patient. So you have to control all that. You have to choose right cannula so that your drainage is adequate, your flow is good, you don't have any problems with the flows, and your SVR or your resistance from the patient is less. So, and then carbon dioxide removal usually exceeds oxygen delivery because it's an easier thing to do. Oxygen delivery depends on hemoglobin concentration and the sweep gas FiO2 and oxygen saturation of the inlet and the blood flow as well. Okay, already we spoke about the goals. These are the targets for VV and VA ECMO. So usually we monitor ACT, which is the bedside point of care test. And then the ACT usually is activated clotting time, which tests the efficacy of heparin. It usually kept at around 140 to 160 seconds, sometimes lower if there is bleeding. So, but that can be affected by a lot of factors like coagulation, coagulopathy, hypofibrinogenemia, hypothermia, etc. So sometimes we have to supplement or complement with APTT also. That's usually kept at around 50 to 60 seconds or sometimes more as required. But the best test is anti-10A, but most of the centers don't have here. Usually it's kept between 0.3 to 0.5 international units per ml. TEG is usually used to differentiate between the bleeding related to heparin versus patient coagulopathy. And antithrombin resistance is seen in some patients with antithrombin deficiency causes heparin resistance in some patients. But the current trend is to give only FFP, no replacement of antithrombin. And thrombocytopenia can occur because of the consumption in the ECMO circuit, and that need not be corrected all the time unless bleeding or platelets are less than 50,000. And the fibrinogen has to be kept more than 1.5 grams per liter or 50 milligrams per deciliter. So when you put on ECMO, you put the patient on rest ventilation, which targeting a peak plateau pressure of less than 20, rate of around 12 to 15 or 20, with a lower right time, and FiO2 of 0.21, 2.25, maximum 0.3. And then a gas exchange happens to the ECMO circuit. And once you're on weaning, you increase your ventilation in VV ECMO. And in VV ECMO, you come down on the flow and you test your heart with your echo. And lactates have to be normal. So there's alternative coagulation like bevaludin and argatropan are used in heparin-induced thrombocytopenia and the testing is not done by um, um, ACT and all. It's done APTT and all. It's usually in a different way. Okay, there are no antidotes for bevaludin and argatropan. But most of the times we use unfractionated heparin only. Only in special cases we require these bevaludin, etc. Okay, they already spoke about goals. Then we go to straight cardiac ECMO. In cardiac ECMO, again, what we said is we are draining from the vein and returning back to the artery. But rest of the things are the same. The pump is the same, oxygenator is the same. So the flow usually we give around 100 to 150 ml per kilo per minute because we want to rest the heart. But this flow can cause afterload to the heart. Okay. But what are the indications? It's for preoperative and postoperative stabilization in congenital heart disease and post-cardiotomy, low cardiac output, myocarditis, cardiomyopathy, refractory pulmonary arterial hypertension, pulmonary arterial hypertensive crisis, refractory arrhythmias, septic shock with septic cardiomyopathy, MISC and ECPR following cardiac arrest. Okay. In all these cases where you can see in the table, a lot of congenital anomalies where there is a restricted impaired pulmonary flow, impaired systemic flow through various lesions, or there is a myocardial edema related to the surgery leading to low cardiac output, or junctional ectopic tachycardia and tetralogy of Fallot with not responding to all the medical management measures. So you don't want the patient to die, so you will just put on ECMO, let it stabilize, control all the inflammatory edema, arrhythmias, whatever is there, and then come out of ECMO after few days. So in obstructed disease like pulmonary hypertension or pulmonary embolus, also it helps because it provides good cardiac output. And then in sepsis and anaphylaxis, it's a distributive shock where you will have to because it is no good, either require hyperdynamic circulation, you will have to give very high flows on ECMO to provide good tissue perfusion. So these are the harbingers of arrest. So like arrhythmias, ventricular tachyarrhythmias, bradyarrhythmias, AV block, etc., where there is rise in lactate, and you anticipate events and start ECMO early in myocarditis. Likewise, persistently reducing EF, prior history of cardiac arrest, sustained VTs, and tissue Dopplers in echo showing significant alteration of the performance of myocardium with high inotropic score and all that. Then in cardiomyopathy, they indicate ECMO, preemptive ECMO. So likewise in arrhythmias, refractory VTs, junctional ectopic tachycardias, torsades, depointers, and all these, before these culminate in arrest, we have to put the patient on ECMO. So what are the objective criteria? The hypotension, despite a inotropic score of more than 20 to 25, with double or triple inotropic support, then low cardiac output causing malperfusion of tissues with the persistent oliguria, diminished peripheral pulses, low mixed venous saturation, raised AVDO2 cap, raised PCO2 cap, lactate of more than 4 and persistently rising beyond that, not responding. And we already spoke the rest of the things. So cannulation strategy. So what are the advantages and disadvantages of VA ECMO? So VA ECMO provides both cardiac and lung support. It's mixed venous is the one which reliably monitors the tissue perfusion and flow delivery is proportional to oxygen delivery. Whereas the disadvantages, it can lead to carotid artery injury when we cannulate the carotids. It causes non-pulsatile perfusion. It can cause emboli to the systemic circulation and CNS stroke. Can also cause the cardiac stun due to high afterload from the ECMO to the heart. So let's see a video which is showing a dysfunction here. This is like this patient had arrested after some time. This is the vitals. See the vitals are 40 by 19, mean of 29. You can see ST changes when patient arrested. So this patient, how you will salvage? So you will have to quickly go for cannulation. How you will choose? You choose your ultrasound. Like what the cannula is guided by the ultrasound diameter of the vessels. So that's the maximum, whatever diameter you get. That should be the maximum size of the cannula in French. That is like you get a size of 3 mm. So 3 into 3 is 9 French. So 9 French is the maximum size the vessel will take. So you have to go one size below, like 8 French to that vessel. Okay. So to avoid congestion and injury to the vessel. So first you have to cannulate both the get both the guide wires, then give heparin. Then after that cannulate, then use your sterile clamps and connect to the prime circuits. Your blood should be ready, at least 2 units of PRBC should be ready uh, before itself, so that if any bleeding happens, you can immediately transfuse them. This is a rough guidance chart for cannulation. If you choose peripheral ECMO, you can, this is on the left, you can see neck versus groin. In the right side, you can see central ECMO. So you open the chest and you cannulate the right atrium and aorta directly. So in peripheral ECMO, we cannulate the internal jugular drainage uh, vein and then return back to carotid artery. Whereas in neonates, or if you choose VV ECMO, we choose SVC2, IVC, return. If we choose VA ECMO, we choose the internal jugular vein and carotid artery. In central ECMO, it is right atrium as the drainage and aorta as the return. Let's proceed to case scenarios. So first case scenario is 1 month old, 2.7 kilo baby with myocarditis with refractory cardiogenic shock. So which cannulation is to be done? So this is a VA ECMO. You can see the drainage from internal jugular and return to the carotid artery here. So it's peripheral ECMO. So you take an incision in the second crease and then you cannulate both the vessels. Usually it's done by surgeon. It's an open technique. They pass the loops proximally and distally so that they can control the vessels, and then they directly open the vessel anterior side and then pass the vessels where you can see in the last part. So once the vessels are secured, you have to mark them. You have to check the position of the vessels in the X-ray. On the left side, the way you can see the tip above the diaphragm of the venous cannula, and the aortic cannula is in the arch exactly, arch of aorta. Whereas in the right side, you can see that the arch of the return cannula has migrated from arch to the it's almost about to come out. So we have to be very careful. Check the cannula position, secure them with the bands, position them properly. Otherwise, you can end up in disasters. So you can check the position with Doppler also. You can see that the flow is going to the aorta from the arch, this arterial cannula. So how do you reposition how do you position the cannulae? So suppose the venous cannula goes into the PFO or coronary sinus or tricuspid valve or into the IVC, you have to check in the Doppler. So and the echo focus, and then you have to readjust that, checking your colors and all that. The tips of the cannula and the color wherever it's going, you have to check and then readjust. Arterial cannula, again, if it's in the right carotid artery or too deep in the descending aorta or ascending aorta reaching the aortic valve, then you have to readjust. This patient, you can see what is the weight. So this is 2.7 kilos. So So 2.7 kilos, we have run around 150 ml per kilo per minute. The lactate reduced from 6.2 to from 11.2, it reduced to 6.2. Gas exchange was satisfactory. That is, there was flow reduction after 1 hour, suddenly to 0.25 liters from zero point 0.4. And mean BP also reduced from 50 to 38. So there was bleeding noticed at the cannula site. PRBC was transfused due to volume requirement. So then ACT was high, so heparin was stopped. Usually we keep ACT around 180. So it's very high. Stop the heparin. Then there was low platelets, low fibrinogens in the labs. So we transfused, flow established after that. So then the mixed venous was good. So how do you establish the oxygen delivery? How do you check that? The systemic venous oxygenation more than 70, and there are tissue perfusion, which is indicated by low lactate, mean arterial pressure around 40 to 45 for a neonate, and the low atrial pressures left and right should be like 2 to 5. So, and adequate compression of the LV and the RV, which you see by LA pressures if you have an open one. But usually this is a peripheral ECMO, so we don't have LA pressures here. We only see the pulse pressure. We should not have a pulse pressure below 10. If you have a pulse pressure below 10, it indicates the cardiac stunning. So on ECMO, is there any role for inotropes? Yeah, sometimes when there is a cardiac dysfunction, you just want to you don't want the heart to stun. So in a peripheral ECMO, you don't have a venting option. So you cannot decompress your heart. So what you will do, you again for that you have to open the chest. To avoid that, we start a low dose inotrope like adrenaline or vitamin, so that your aortic valve opens and prevents stasis and myocardial stunning. Uh, but unfortunately, this does not provide adequate rest. However, we have to use that in dire circumstances with extremely poor ejection and myocardial stunning. But most of the times, tissue perfusion is taken care of ECMO. But for some cardiac support, you have to give inotrope, roughly like 0.02 to 0.05 mics per kilo per minute of adrenaline. So if the patient is having like a distributed shock or septic shock, additionally, you may require some vasopressors like vasopressin or noradrenaline, because it's a test, peripheral tissue shutdown, and you might require these vasopressors. ECMO is not going to open up your tissues in this situation. However, we need both support of ECMO as well as vasopressors. If the BP is high, again, it will cause afterload on the heart. It will resist the flow of the ECMO circuit. So you have to use vasodilators if the BP is high. So is flow adequate? No, it's not always adequate. In that situation, you have to do venting. So you have to use a LA vent to uh, decompress your heart. So you can also connect your CRRT to the ECMO circuit if it is required. So once the heart recovers, you can see the improvement in pulse pressure. You can see it's like 76 by 53. So patient improved. You can pulse pressure improvement. You can reach to lower flows, which are called idling flows. You can see the good heart function. Can come to 25 to 30 ml per kilo per minute. Every fourth hourly, you wean the heart within the ECMO, you can come down on the ECMO support. And once the EF is good, more than 40%, lactates are low, you switch over the ECMO. Okay, there is another patient, 2.8 kilos, who underwent arterial switch operation. He had ST changes and low cardiac output. So we did open cardiac massage. You can see that. Oh, you're not playing this. Yeah, it's an open cardiac massage. Just opened. Okay, and then going to on ECMO support, put the patient on CP, and then back to the ECMO circuit, and then run the ECMO. First, initially you go on the bypass because you don't want the patient to suffer, because already you have a bypass circuit ready. Then you go on to the ECMO circuit. Okay, this is the patient who is doing well on ECMO, awake with no neurological issues. Okay, you can see he's totally moving his limbs. He had some seizures later, but they were controlled. So this is the central cannula in ECMO. In the bent one is the LA vent to decompress your heart. Okay, all the cannula are well secured. The right side one is aortic cannula, and these are the positions of the cannula with the drainage cannula and return cannula. Here is the L11 vent. So that's the L11 coming from the side through thoracotomy. Sometimes you can close your chest and get like that. Okay. Now coming to some literature. So high risk ECMO is there in some patients who require major surgeries with high STAT score and high vasoinotropic score. So residual lesions can be a challenging post-operative. So we have to address the residual lesions as soon as possible. Otherwise, we will end up in irreversible problems and we cannot wean off ECMO. So early ECMO in theater is good. Some studies from Chaturvedi et al. And Kolbos et al. Have shown that early ECMO done in OR is better and has better survival than the late ECMOs. So this is a paper where it's just CICU start was done by Chaturvedi et al. There you can see good results as per this Kaplan-Meier curve. So a lot of, but the survival you can see is only 47 to 50% in this VA ECMOs in all these congenital heart disease. So in single ventricle, again, you will have to use different cannulas for different vessels like SVC, IVC separate. And again, you might have to decompress multiple vessels. You have to go for additional cannulations if you cannot decompress with your regular cannula. Okay, ECMO in BT shunt again is challenging because there is a lot of steel. So you have to provide good circulation in that by providing higher flows. Okay, let's stop at this stage. This neonatal ECMO is demanding, needs familiarization with cannulation strategies. Cannulae are placed superficial and potential danger of migration can occur. Neonatal VV cannulation is challenging but can be performed after large experience. The flows are little but need huge attention even for small alterations. Even minor changes in cannula and intrathoracic pressure can affect the flows. Success rates are high in adults if timely ECMO is performed. Focusing on finer aspects can improve outcomes in children. Thank you.